sat in on. And I wanted to learn this really well, and I wanted to know it, one, because I'm taking boards in 2 months, and the other is because if it's hard, I want to learn it. So here are your objectives. You're going to know the etiology and the cardiomyopathy of these diseases. We're definitely going to talk about clinical manifestations. How do you interpret it on an X-ray, laboratory findings? We'll know which type, what they say on the interpretations. I'm going to leave all the imaging to the radiology section of cardiology, okay? The next objective, differentiate between emergent and non-emergent. Just mark that out. You're not going to be tested with that, and you're going to see why. Because it's emergent when it's emergent. Until then, it's not emergent. So it doesn't make sense for cardiomyopathy, and you'll see why. You'll have to know what type of diagnostic modalities we need to order to diagnose these. And then also education and referral and treatment. So this is the definition for cardiomyopathy, right? This is stupid. Cardio, heart, myo, muscle, apathy, wrong. Something's wrong with the cardiac muscles, right? Done. That's all you need to know. Okay, so this slide, this totally will affect you. When I went to King School, we learned cardiomyopathy with hypertrophic, dilated, and restrictive. Those were the only 3 cardiomyopathies we learned. And those were the headings. So under hypertrophic cardiomyopathy, you had these other little ones. Under restrictive, you had other ones. Under dilated, you didn't have any. But we figured out cardiomyopathy was actually diagnosed for the first time in 1950. So this is a really young disease. I mean, it was 1957, because I thought my mom was born in 1950. So this has been within my mom's lifetime, right? So this is a very new disease, so you can imagine that it's made a lot of changes in the way we diagnose it, the way we treat it. And so whenever you think young and changes, the names are going to change. And that's really annoying to students, because have you guys ever lived in a place where the street changes names depending on where you go north? Yeah. That's the most annoying thing ever, right? Like, what street are we on? Are we on Yukon Parkway? Are we on Mustang Boulevard? What are we on? So this is the same thing you're going to run into on rotations. Your supervising docs are going to call it something else than you call it, okay? So if they say hypertrophic cardiomyopathy, that can mean anything in this category I'm going to show you. So the American Heart Association, in I think 2005, reclassified this. So this is really recent, guys. What it will show is in 2005, this American Heart Association will be what you're tested on boards. Anything that's been changed within 5 years is not testable on PANCE, but if it's been after 5 years, it's testable. So when you get PANCE test questions, it will be under the American Heart Association classification, okay? So that's all you need to know. Primary, you have 3 types, genetic, mixed, and acquired. In secondary, you're going to learn all throughout PA school, is whenever it's a secondary problem, it's not my fault. It's somebody else's fault causing it, okay? So secondary means it's not the heart's fault. Some other disease is causing these heart muscles to act funny. So this is the American Heart Association guideline here. This is the primary cardiomyopathies. These are the main ones we're going to look at today. Genetic, and I've circled actually in red the ones we're going to talk about. The most important ones are the hypertrophic, restrictive, and dilated. We didn't even know there were these other ones until recently. But the thing about these other ones are they're so rare that you don't need to know them to be a generalist. Now, if you go into cardiology, I would pick this slide back up, and I would know what all of those genetic hypertrophic cardiomyopathies are. Okay? Until then, just learn the ones I'm circling. That's all you're going to be tested on. I put this one in blue because we're going to talk about it a little bit at the end of this lecture. So you can see for dilated cardiomyopathy and restrictive, those are both mixed. So there's a genetic component and environmental component, right? There's something, some type of other issue. The other part of this lecture that you need to know is we are going to spend our entire time talking about the ventricles. We're not dealing with the atria this lecture. So when I talk about this is feeling or this is contracting, I'm always talking about the ventricles. Because for cardiomyopathy, that's all that really matters. I want you to think in diastole, the muscles are dilating, they're getting bigger, and they're filling up with blood. In systole, the ventricles contract, and they're ejecting the blood. Okay? So let's talk a little bit about hypertrophic cardiomyopathy. So Kim, right, could kindly help me draw these up here. In normal blood flow, okay, so first I should tell you, when you look at this, this is the mirror image of what you see in the heart. So your right is going to be the left ventricle, okay? So where is blood coming from in the left atrium? The lungs. It's red, it's oxygenated. And the right is coming from the body, it's blue, it's run out of oxygen, it's got to go back through, correct? So normally, when the atria are filling, there's still a little bit of blood left over from the previous cycle. The amount that the ventricles can push out, and the part that's left over will determine your ejection fraction. A normal ejection fraction is 55%. So if you can get out 45%, you're good. Okay? So when these ventricles constrict, when they contract, the atria for a second are empty, right? And the blood is being pushed out from the ventricles. And then we go back to this, right? The atria fills back up, there's a little bit of blood left over. Right? We all good there? Okay. So with hypertrophic cardiomyopathy, and as I talk, I want you guys to continue to advance your slides, and I'll try to stay up with you too. So there's a genetic issue here. It's an autosomal dominant genetic issue. And these are, you don't have to know these MYH, but these are the gene names that they've identified that cause the issue. What they cause these heart muscles. It's a deficiency. The heart muscles are not aligned appropriately. Normal heart muscles are parallel, and they help dilate and they help constrict. With hypertrophic cardiomyopathy, these muscle cells are just, they're crazy, right? My sister. They're just nuts. So what happens is what they do, the heart, when it has a normal push out, these diseased muscle cells doesn't get all of the blood out like it should. And what's left over is like this. Okay? And so the heart says, the body says, hey, I'm not getting enough blood. I sent you more, you didn't give me back enough. So it comes in and it makes these heart cells says, I need to make more heart cells so I can constrict, so I can push more blood out. And so you see how this just becomes an inevitable. It just gets more and more. The worst part about this is the septum. The septum gets it worse. So the septum gets really, really, really hypertrophy. Really bad. So now you have two problems. This decrease in the septum here. One, you obviously can see that not enough blood can fill up, right? So that's an issue right there, not enough blood filling. And then what you do get in there, when you try to push it out, it has this narrow little opening to get out from, which that causes an obstruction problem. These ventricles get very stiff, and then they don't start dilating very well, and they don't start constricting very well anymore. So you guys, if you've ever heard of, who has not heard of a young athlete collapsing on the basketball court or the football field and having sudden death? This is what they have. Hypertrophic cardiomyopathy is their disease when that occurs. So why is it that this happens when they're on the basketball court?
Their heart's overworking already.
The heart, it's overworking how?
Trying to pump more blood out.
They're not getting
Why? And what happens when you exercise? Increased heart rate. This heart's beating so fast, it can't feel fast enough because it's not dilating very well, and it can't push out enough because this is more and more obstructive. Okay? So what you really want to do is you want decreased heart rate in these patients. So what happens? What do they look like when they come to you? Again, the way to diagnose this, 80 to 90% of all diseases will be diagnosed history and physical exam, correct? So they become short of breath, especially during exertion. And like I can relate to this. I was short of breath for about 3 weeks before I told a medical provider. And so these kids, they'll think, well, I'm just short of breath because I'm not fit enough, right? I just need to keep exercising harder and I'll get less short of breath. And again, it goes undiagnosed until sudden cardiac death. They may also have chest pain during exercise, and that's because the vessels that supply the heart don't have enough blood to them. They get ischemic at times. They'll have palpitations, so actually feel their heart rate. And again, syncope is the most significant finding here. If you have a young athlete that comes in and say, I passed out when I was exercising, you work them up every time. What you will find on physical exam is, remember Shelley was just talking about valvular leakage, so there's a systolic ejection murmur that I'm not going to cover that Amy will. This is it. This is hypertrophic cardiomyopathy. What happens is you have such a forceful amount of blood. This atrium's like, I gotta get more blood in here because the heart's not getting enough. But it squeezes it so fast that you hear blood hitting this wall. And also this wall is so close. So you hear the shutting of the valve, and then you hear the blood hitting that septal wall that's hypertrophy. And that gives you an S3. And you also have the ejection murmur of when the blood does get out, you can hear it going against turbulent flow. It's going against that already narrowed canal. Just like if it was pushing against a valve that wasn't fully closed, right? When you're trying to push something out of a tight opening, it makes noises, just like with your murmurs, okay? So if you hear a murmur, and especially when you're new in practice, you're going to be like, oh, I think I heard something, I'm not sure. You want to try to do some tests, just kind of verify. If you did hear it, if you do think you hear a systolic ejection murmur, have them Valsalva, which you guys know what Valsalva means, right? Bear down. So when you Valsalva down, it causes constriction of the heart muscles. So when it constricts, do you think this murmur is going to get worse or better? Worse, right? This opening is going to get even more narrow, and you're trying to squeeze more blood out of a smaller opening. So the murmur's getting worse. The opposite of that is if you get them to give you a hand grip, give them like a rolled up towel and have them squeeze down the hand grip, what that does is that will increase your total peripheral resistance, it'll increase afterload, and it dilates these muscles. So then you have a wider opening here for the blood to push past. You'll still hear the murmur, but it won't be as loud. In Valsalva, the murmur gets louder. Okay? Everybody with me? Awesome. Have you guys heard of a PMI? Point of maximal impulse? You'll learn this in phys die. It's where you can lay your hand on someone's chest and actually feel their heartbeat. Usually it's down in the 4th to 5th intercostal space, mid-clavicular. And when you lay your hand there, you normally will feel this heartbeat. People that have hypertrophic cardiomyopathy, their ventricles are larger, and so it moves their heart closer to the skin. So their PMI will be even heavier. It'll be prominent. Sometimes you can even see it if they're laid down and the ventricles are hypertrophied enough. So that's just with inspection and palpation that you would get the PMI. So for all of these cardiomyopathies, the gold standard diagnosis is going to be an echocardiogram. An echocardiogram will tell you, they look at heart muscles and valves. And EKG looks at electricity, heart electricity. So when you get an echocardiogram on a patient with hypertrophic cardiomyopathy, it shows us this increased septal thickness, and the numbers aren't important here. Sometimes if the hypertrophic cardiomyopathy is big enough, you will then see left ventricle hypertrophy on EKG. But usually that's later on in disease. Unfortunately, a lot of times these tests are done by muscle biopsies during an autopsy from sudden death, from people being asymptomatic. So that showed you the normal heart muscles versus what the diseased heart muscles look like. You can also do a genetic test. When do you think you would do a genetic test?
When the parent has it?
It may not be the parent, because usually how is it diagnosed? And yeah, if a sibling or cousin has a sudden death accident or sudden death during exercise, everyone in the family needs to be screened for this genetic test, right? Now, if the parents do get diagnosed because they had the genetic test earlier, their kids need it too. So 1 to 3% mortality, that's pretty high. I mean, out of all the cardiomyopathies, this is the highest mortality rate. So this is the one that gets tested on the most. Treatment, you have to slow the heart rate down, allow more time for those ventricles to fill up, and then you want to find ways to increase the cardiac output. And we can do this with medications. Beta blocker and calcium blockers are the most commonly used. You can do an implantable cardioverter device, which will keep the heart beating when there's not enough blood flow. So you can then reperfuse them when they make it to the emergency room or the clinic. Cardiac surgery, in severe cases, they'll go in and try to shave out part of this diseased muscle. It does grow back. It's not a cure. It's just a fix. And then in severe cases, they can become candidates for heart transplantation. So what do we tell these patients that we find this ejection murmur and we do an echocardiogram and we find out they have hypertrophic cardiomyopathy? Well, the first thing we tell them is no competitive sports. Then screen the family members, encourage them to eat a healthy diet, stay up on all their immunizations, and give them a medical bracelet to wear at all times. Because if they suddenly collapse, you need to know the cause. And that's what the medical bracelet does. And these kids, these patients are followed by a cardiologist either every 6 months or yearly. All right, so now we're going to have a quick discussion. You don't have to use your computers for this. We're going to talk a little bit about hypertrophic cardiomyopathy. So when I was teaching at OU, we used to have the students wrote a paper about something that interests them, and they looked at peer-reviewed journals and compared like the most current evidence-based medicine out there. One student who had been an athlete previous to coming chose to write her paper on, should we screen all athletes for cardiomyopathy? Okay, you can see like 1 to 3% would be beneficial, right? So what are some pros to screening all children athletes for cardiomyopathy?
Save the lives of 1 to 3%.
Yeah, we can prevent death. Okay.
You want to have it, you can test all their family members.
I mean, it could even go greater than 1 to 3%. It could be even 2 to 6%.
You can prevent it if you know you can
Yeah,
say competitive sports and
we can slow that disease down for those patients. What are the cons?
Cost.
Cost. Can you think of any others?
Taking someone's life away.
Well, if they love sports, I mean, you
Because
really
sometimes-
give them their life, but you just wouldn't give them their passion for life.
But
You
in
take
some
that away.
cases, it may not ever come up. So they could have it and you could tell them that they don't need to play sports, but it may not ever show up.
Right?
It may not ever affect them the way that in death.
Yeah, they may not ever get tachycardic enough to do that. So I'm going to throw something else out there for you. In Italy, all children that are athletes get an EKG prior to participating. Do we do that in America? No. No. Who are our student athletes? And when you went to the provider for your sports physical, what was the maximum amount of time you spent?
10 minutes.
5 minutes.
5?
Yeah,
10?
They set us up at school and we had like stations. And we
Yeah.
just, like,
You
set
go in
us
the
around
gym,
stations.
and like there was like 10 people like screaming and playing basketball in the corner, and here's the provider listening with their stethoscope to your heart, right? That's a little scary, huh?
They're stricter in college.
Yeah.
College is.
And sometimes, a lot of times in college, what happens is they will have a provider that they recommend all their athletes go to.
They had
I was
our
gonna say, it's in our division too.
Yeah.
Yeah, your division is different too,
Yeah.
because NCAA, they're pretty
They're a lot
heavily
stricter.
regulated.
Yeah.
So we had to go through a bunch of stuff.
And I guarantee you the professionals do too. I guarantee you professional teams hire their own physician to come in, and it's a lot different.
I was worked up for this at OSU. So you never see a cardiologist, like even at symptoms of this at all.
Yeah.
But it wasn't like regular practice.
So the point of this evidence-based talk, that the outcome was that really at least a minimal EKG is recommended. They would understand not going straight to echocardiograms, which is the gold standard because of the cost. But really in America, we should start screening all athletes with an EKG. It's not gonna happen until we can get insurance to believe it. And insurance is usually about 5 to 10 years past evidence-based medicine. What I'm telling you guys this morning is this is a serious issue. So when someone comes into your clinic for a history and physical for sports, they're gonna be like this, I gotta go practice. Moms will be like, I've gotta drive them to Edmond in 30 minutes for practice. Get them out. Is your medical license on the line? Spend extra time on their review of systems and their past medical history for heart issues, and they will lie to you.
Oh, yeah.
They will lie to
Sure.
you. So be extra careful when your physical exam. Be in a very quiet room, okay? They will underplay their symptoms every time because they think it's part of, they're either not trying hard enough or they need to exercise more, and that's why they're short of breath. Any questions about that?
How often will this show up in EKG though?
Only when it's pretty severe.
Okay.
Only when that left ventricle is hypertrophied enough to cause the changes on EKG. But the evidence does show that you will see it on EKG prior to sudden death. But again, that's why they come in every year, right? For these sports physicals, for things to change. You will hear the ejection murmur and the S3 very early on.
You could like scare them a little with this, right, to make them tell you, okay, like
Do whatever you want to say, your
Honestly,
medical license.
You could have sudden death.
Yes, that mother may be in your clinic every day from then on out, but with everything
All
else.
right.
Yeah, absolutely.
Okay.
Especially if you think they're hiding something from you. And that's always, I always try to get whoever else is in the room involved. So I'll get the history from either the parent or the child, whoever's at age appropriate, and then I make sure to double check it with the other one. So you don't have it, you never have any chest pain, you never feel dizzy or lightheaded. Mom, no cousins or uncles or aunts ever have any type of sudden death, playing sports. You see, you just kind of, you ask the same question in different ways to different people also available. Okay, let's go to dilating cardiomyopathy. So what happens here is these diseased heart muscles, they can't dilate. I'm sorry, they can't contract. So you have the blood filling up. And the muscles can't contract all the blood out, so you're left with a higher volume of blood. They have a lower ejection fraction, right? So what these diseased heart muscles will do, remember they're diseased, that's what's causing this. The body will say, hey, I'm not getting enough blood, you need to do something. So in cardiomyopathy, what happens is these ventricles will dilate to try to get more blood in there. Okay? So this helps for a little while, right? And then not enough blood's getting out, because it's not contracting, and so it dilates until maximum dilation. And this ejection fraction just keeps going down, down, down. The more they dilate, the lower this ejection fraction gets. Dilated cardiomyopathy. So when the ventricles reach their maximum dilation and they can't dilate anymore, the body's still telling the heart, hey, you're still not giving me all the blood I gave you. I need some more. So then the atria start to contract. That's usually when you start seeing the predominant symptoms. when it's that far progressive. So what happens here, remember this was a mixed, one of the primary mixed cardiomyopathies, so there is a genetic component where these damaged heart cells just do this. There's also an inflammation of the heart can cause this when you have myocarditis. In pregnancy, dilated cardiomyopathy is a common finding. We don't know why, but it starts in pregnancy. It doesn't get better after pregnancy resolves. We just know pregnancy is a trigger. Now we know that there's probably a trigger between, in pregnancy the heart needs more blood. So you have an increased demand. And so there's some trigger there that says you're still not giving me enough, you're still not giving me enough, and it keeps dilating. And then sometimes dilated cardiomyopathy just don't go away. So the clinical manifestations, two types. Whenever you see fatigue, lightheadedness, syncope, that means the body's not getting enough blood. Okay, you're not getting enough out. When you see swelling, edema, ascites, you've got a backup of blood. So that means the atria now are dilated to their max, and you've got a backup of blood. And where does that backup of blood go? To the lungs. Good. You start having dyspnea and exertion. I walk and I'm short of breath because my lungs are full of blood, full of fluid. I start getting swelling in the lower extremities. Edema. If you guys know what ascites means? Like the fluid on the tummy. They will also complain they'll be tachycardic, they'll be short of breath, and sometimes they'll have elevated blood pressure with this too. So in a young person with a new onset of hypertension that's living a healthy lifestyle and with no genetic components, think dilated cardiomyopathy. Okay? No genetic components of hypertension, think dilated cardiomyopathy. So even later on, whenever it's continuing to back up in the lungs and throughout the body, you can get cyanosis and clubbing. That's when there's even less blood getting to the extremities. Jugular venous distension, these neck veins. The veins in the neck get backed up with blood. Pulmonary edema, crackles and wheezes make sense. The S3 gallop, now not because it's hitting this atria, but because these ventricles are so deep, it's like throwing blood into a drum. When it hits the wall, it makes an extra sound just because it's had further to travel. Does that make sense? And then also hepatomegaly, enlarged liver from backup, little hypertension. So, there's a couple of things we can do here to diagnose this. We can, I don't want to get too far away from my notes. You can get a BNP, a brain natriuretic peptide. This is not specific for dilated cardiomyopathy. Usually what we get BNPs for is congestive heart failure. All it tells you is that these muscles are being stretched. And you can see how these muscle fibers are stretched in dilated cardiomyopathy, but they're really stretched in congestive heart failure. So it's not specific, but it will be elevated. The EKG, however, it's abnormal, but it's non-specific. It says abnormal, but really can't tell anything about it, which happens all the time in clinic. You'll get an EKG and it comes back abnormal, non-specific. Like it doesn't look like anything you've been taught in school, but it's not normal. But if you do an EKG on a person you're suspecting has dilated cardiomyopathy and it's normal, it absolutely 100% rules out the disease. So a normal EKG, take dilated cardiomyopathy off your differential. Abnormal, non-specific, keep it on there. You still got a lot of other things in your differential, but keep dilated cardiomyopathy on there. If you get a chest X-ray on these patients, it will show an enlarged heart, cardiomegaly, because these dilated ventricles, right? And an echocardiogram, again, is your gold standard test. We treat this exactly the same that we treat CHF, and ACE, beta blockers, diuretics, or some common medications we use. What do we tell the patients here? We tell them to maintain, just be as heart healthy as possible. So exercise, don't smoke, don't drink, don't use drugs, maintain a healthy weight, eat a heart healthy diet. DASH diet is one of the heart healthy diets. And cardiology also follows these patients as well. primary restrictive cardiomyopathy. So the problem here is that it's still a disease of the muscles. And here, these muscles cannot relax. Stiff muscles. If they get stiff, and so then they don't push enough blood out. But here you don't have that negative feedback loop where it keeps getting worse and worse and worse. It just is what it is. It's restricted. It doesn't dilate, it doesn't constrict very well, it's just stiff. But it is what it is. So you get what you get with that. You have a decreased volume of blood that leaves the heart just like all the other ones. It's very, very rare. Only 5% of the world's population, not America, the world, okay? That's very little. And it can be caused of two different issues. Fibrosis is one issue, or infiltration is another issue. Types of fibrosis, radiation. So any cancer patient that's ever been on radiation treatment, now primary restrictive cardiomyopathy is on your differential, forever and always. And sometimes we don't know what causes it. Infiltration is another cause of it. Amyloidosis is an autoimmune issue, and it deposits protein in these heart muscles. It causes it to be stiff. Sarcoidosis is one. It deposits granulomas in its heart tissues. It causes it to be stiff. I was so happy when I saw bullet 3, genetic diseases where metabolites are deposited, because I taught you about one of these. Anybody remember it?
Nice.
Stellar, kids, stellar. It's not cystic fibrosis. I only taught you about 2 other ones. Huntington's disease and thalassemia. It's thalassemia, right? So remember when they got an iron overload? And what was that because of?
Oh my gosh.
They would get increased iron. Why?
Oh my gosh.
Kids, this was like a couple of weeks ago. I'm just kidding. I know, it was such a, you're going to have to start building on these things through physicals. Remember when they would get infused, they would get transfused? They would have extra iron because the problem wasn't the iron, it was the formation of these blood cells. So then they got all this extra iron deposited into the heart in places, and they had to go through chelation therapy to get rid of some of the iron. Oh yeah, I totally remember that. So that's one of the causes, okay? Hemochromatosis, same thing. If you guys are a little bit scared about on rotations, it's just where you need to be. So I'm going to try to keep you over the next 6 months.
Terrified.
So here the ventricles, they don't relax, they don't dilate, and the muscles stay the same size, so the heart's not filling properly. It has decreased filling, there's decreased blood leaving the heart, and this is from diastolic heart failure. The only systolic heart failure we talked about, or can you guys tell me which one of these is systolic heart failure between restrictive, dilated, and hypertrophic?
Dilated.
Does this slide help?
Oh.
So which of these diseases would be systolic heart failure?
Dilated.
Dilated, because it's a problem with constriction, right? They're dilated so they can't strict very well. So this is the only systolic heart failure. This is diastolic, this is diastolic. Man, I can hear your brains, they're expanding, I feel it, beautiful. All right, so what do they look like? These patients in clinic, they're short of breath, they're weak, and they're fatigued. Why? It's not getting enough blood out. They are decreased in oxygen because there's not enough blood leaving the heart to oxygenate everything. They get edema and ascites because of fluid backup. Good, good, good. So how do we diagnose this? Chest X-ray will show pulmonary congestion, but the heart size is normal. The heart size does not get any bigger. It's not moving, guys. It's the same size no matter what you do to it. So you have pulmonary congestion with normal heart size. On EKG, you have low voltage QRS complexes because you're not getting that squeeze from the ventricles. They're just kind of It's like me doing sit-up, which is not very much, right? An echocardiogram, it'll show the increased ventricular thickness and maybe atrial enlargement because it's still, the atria is trying to get bigger to give the ventricles more blood. So if this is only 5% of the world's population, why are you learning it? Right? Come on, this is really rare. Why are you teaching me this? The only reason we teach it is because it looks just like pericarditis. On all of these tests, it looks like pericarditis. So you're going to have to be able to differentiate it between that. And the way we do that is a cardiac angiogram, a cardiac MRI, or a heart biopsy. And you guys know if we're doing a heart biopsy, it's usually an autopsy, right? For people that have primary restrictive cardiomyopathy, there's a very poor prognosis for them. This is not curable like pericarditis. It's usually fatal when diagnosed in infancy. It gets progressively worse, and heart transplant is the only chance of survival. Okay? I've got one more quick little thing to go through, and then we're going to be done. This is a short lecture. So, back to this slide. When I was looking through this, I knew hypertrophic, I knew DCM, I knew restrictive, and the only other one I had ever seen in clinic before was stress provoked. Does anybody speak Japanese? Does anyone know how to pronounce that? Takotsubo? We call it broken heart syndrome. You guys ever heard of broken heart syndrome? Ever someone dying from a broken heart? For reals?
For real.
This is Takotsubo, or however you say that. I don't know how to speak Japanese. But it is really cool because what Takotsubo means is it means an octopus trap, which if you Google octopus trap and images of broken heart syndrome, they look a lot alike. The heart just takes on this, the ventricle takes on this really funny shape, like this, and that's what an octopus trap looks like. So whoever found the disease named it. He went in his backyard and said, hey, I got that in my backyard. It's an octopus trap. So I named it. So I'm going to show you guys a video that the OAPA, the Oklahoma Academy of PAs, paid for to be put on. They did this to raise awareness of PAs in the state. We went to several supervising physicians and hospital administrators for this video and sent it out statewide and even national-wide just to kind of booster the PA name in Oklahoma. I was the public relations coordinator at the time, so I got all these people to come in, and I'll be damned if they didn't put me in the video, which did not make me happy. I was not supposed to be in the video, okay guys? So, but the patient here is really my patient. She has given me consent to talk about this. I mean, she was on the video. And she's going to tell her story, and then I'm going to tell my story.
A PA saved my life.
This is really big for the PAs.
Janet Irwin woke up one morning with trouble breathing. She visited a physician assistant who discovered she was suffering from a heart attack and sent her to a hospital. This nurse spent 5 days there and survived thanks to the help of a physician assistant, or PA. I've always felt very confident with all the PAs that I've ever seen over at the urgent care clinic at Family Practice. Statistics show physician assistants is a rapidly growing profession. In Oklahoma, PAs see more than 3.6 and are high in demand.
Especially with things coming up like the ACA, Affordable Care Act, the utilization of PAs is becoming more and more necessary, and the opportunities for PAs out there are becoming much more evident.
A good surgeon or a good doctor is going to be usually booked up for several weeks, so if they need to get in sooner, then we can always get them in sooner.
Because physician assistants, or PAs, and doctors are educated by the same medical model, PAs play many roles and perform a majority of duties similar to physicians. In rural Oklahoma, they are sometimes the only healthcare providers for hundreds of miles.
You won't find a better group of people to work with. They're wonderful, they're compassionate, they're not only well educated, but very compassionate and care about humanity.
Studies show PA's labor costs are more affordable. They are dependable and work under supervision with a physician as a team. Over the last 15 years, Dr. Robert Salinas had the opportunity to work with many PAs.
As a physician in caring for patients in various settings, I've been impressed with the caliber of physician assistants that I've worked with. I think the training that they receive is fantastic. They're able to step in on a given moment's notice and carry out the duties that will optimize healthcare for a lot of our patients.
Salinas says PAs are also reliable.
Many times I have other responsibilities where I am confident that our PAs can step in and see patients on my behalf and offer the appropriate level of care.
The training for PAs is top-notch. Their level of education and hands-on clinical training last about 27 months. Continuing education is also exceptional, especially in Oklahoma. The profession means job security and a promising career for up-and-coming PAs like Jessica Savage.
From my perspective, being a PA is going to be a much more fulfilling role for me. So it may be a hectic lifestyle. I may be in a position where I'm on call. You know, I'm going to get that sense of being able to positively influence somebody else's life.
Today, you will find more than 1,200 PAs in Oklahoma practicing in family medicine, orthopedics, surgery, and preventive care.
I get up every day and I love my job. I get to take care of patients.
They strive to treat the whole person, spend more time with patients, and promote healthy behaviors through all life stages. For Janet, it was that one particular PA's knowledge and quality of care that saved this nurse's life.
Yes, I feel like she was very instrumental in making sure that she got all the proper information, was able to make a very good medical diagnosis and send me where I needed to go to take care of myself. A PA saved my life.
That's so embarrassing.
You didn't say you're the star.
I'm not. I do want to show that you guys will see those people. Dr. Salinas is coming to lecture in geriatrics. Shannon Carmachet is an orthopedic preceptor. You guys will see on rotations. And Sarah Hartnett, the other blonde, she works at the Kidney Transplant Center, and she also takes some COPA students. So you will see these faces. Susan Thomas is the executive director of the OAPA. You guys who went to the last board meeting, she was there. There's also another board meeting tonight for anyone who wants to go. So let me tell you about this Janet Irwin. This lady she's a firecracker. So I have seen her probably about 3 or 4 times in clinic only for acute care issues. She is not she's a nurse. She is a preventative nurse at Children's Hospital, but she did not believe in self-prevention. She didn't come in for her yearly. She would do her tests that she needed to, but she has seen a cardiologist. She had some hypertension issues. She came to me. She walked over from Children's Hospital, came to my clinic, and said, I think I am getting adult onset of asthma. Okay, rare. She's like 57. I'm like, okay, tell me why. I am just so short of breath all the time. I'm just getting more and more short of breath. It started out probably about maybe 2 or 3 days ago, and it's just increasing. And I've just walked over from Children's, and I'm just about to pass out. I can hardly breathe. So I grab an O2 stat, stick it on her, and her O2 stat's about 94, which is abnormal. I usually like to see 97 to 100, but it's not critical. And so right now, lung issues and heart issues are on my differential. Keep going, family history, past medical history. She does have some heart issues. She's on some heart medications, beta blockers. She has had some stress recently in her life. Her husband lost her job, and he's not taking it well. She's trying to be really supportive. They've been together for like 40 years. They were high school sweethearts, and she just loves him. And she's just worried he's not doing well. But really no other family stress. They have a child that's causing a little bit of disgruntlement in the family, but it's not really bothering her that much right now. And I do a full physical exam. Her heart rate's a little bit tachycardic, But I did not hear any murmurs, systolic, ejection, diastolic, nothing. And I just didn't feel right about it. Like, she is too well educated to know if she came over here with something's wrong, and I feel like she's playing it down. So I get an EKG and it looks identical to this. The only thing different was that her heart rate was a little bit faster. And so I think the image on the heart rate said abnormal, non-specific changes cannot rule out acute MI. Because you're going to learn in EKG, there are a little bit of elevation here. There's some elevation in these leads, but there's no reciprocal changes. This is elevated, which you're going to learn about this in EKG. But with ischemia, you typically tend to see a reciprocal change where there's T wave in depression. And she just didn't have any. And I said, who's your cardiologist? And she said, oh, it's Dr. Lockwood here on campus. So it was really the perfect storm. I called her cardiologist's office. The cardiologist was actually in clinic that day, which never happens. She was in clinic, and I got hold of the nurse, which never happens. And I told the nurse, like, hey, I'm seeing one of your patients, and her EKG does not look normal to me. Can you send me her previous EKG? And she's like, yes, I'll send you her previous. You send me what you have. Dr. Lockwood's here in clinic. She'll take a look at it. About 3 minutes later, my cell phone rings, and she's like, Amy, this is Dr. Lockwood. She's English. You need to send Ms. Irving right to the doctors, right to the emergency room. And I was like, okay. And she goes via IMSA to the ER, and they capped her within 5 minutes of arrival. And it literally saved her life. And I don't know, I never learned about broken heart syndrome when I was in PA school. And I want you guys to feel confident that you're not going to learn everything. We're not going to teach you everything, but you have this skill set, okay? You're going to know when something's just not right, and you're going to know when to call for help. I knew that this wasn't an MI, but I didn't know what it was. I wasn't smart enough to know what it was. So I knew I needed help. If we can teach you anything here, it's when to ask for help, okay? And it really will make a difference. So that's my other claim to fame, other than the avocado ring in the closet of children's. Any questions about cardiomyopathy? Do you feel like there's any gray areas? Do you feel like there's anything you don't understand that's going on with the pathophysiology of the disease? Yes.
So for the three of them that we talked about, the presentations, are they both right and left at the same time?
No, they always start out left. You only have right. Okay, wait. Are you talking about the ventricles are affected?
Yes.
Yes,
So,
the ventricles are affected equally at the same time.
okay.
But the right sided ventricle is just not as important clinically as the left sided ventricle. So what you see left-sided heart failure symptoms previous to right-sided heart failure symptoms. By the time you've made it to right-sided heart failure symptoms, you're talking about that pulmonary congestion, the backup, the swelling, the edema. It does affect it at the same time. It doesn't just target the left ventricle for the hypertrophy or the dilation or the restrictive. But we only see clinical signs and symptoms first related to the left side. Does that answer it?
Yes, it does.
What is it?
Will you see cardiomegaly in the first one?
Hypertrophic?
Like at the very end of it, like the worst case scenario, I guess?
You will.
Like you wouldn't see it necessarily right when they first were symptomatic.
Right. And remember on a chest x-ray, you're not seeing the thickness of the ventricles, you're only seeing the outline. So it will look like an enlarged, but it may not be as enlarged as it is in an echocardiogram, because you're only seeing the silhouette of the heart.
Yeah.
So depending on which way it's turned.
So you just can't, you can't get a chest x-ray and think, oh, it's the dilated one. You have to.
Right, you still have to put together everything else. Okay. And you're not going to be able to diagnose it with a chest x-ray.
Yeah.
It's a clue that leads you to the disease. But what's the gold standard? Echocardiogram. What else? No. What? No, I heard your question. Echocardiogram is the same thing as a TEE, right? It's not. TEE is transthoracic. It looks at it from the top. An echocardiogram is just like an ultrasound. Like, have you guys ever seen like the little wand that you put over someone's belly? It's just like that. It's just a tiny wand that goes on the outside of the skin.
Is that the TTE?
Yes.
Okay.
TTE. TEEs are kind of invasive. People don't love them. I've had multiple echocardiograms, and I think I slept through the last 4. Real pregnant. They have you in a cold, dark room, and it's just perfect.
Why would you do a TE instead of a TT?
See the backside? Yeah, see the backside of the heart and the right atrium. And there's some valves that you can see better with a transthoracic. And it looks at the posterior as well, where you can only see certain valves and sizes with an echocardiogram.
They say that TEEs are more for looking for clots.
You can look for, I mean, you can look at different areas, clots in different areas of the heart with that, because you can see all the blood vessels. And the blood vessels that are more likely to cause clots and make problems with posterior side. Good. I think you guys have class at 3, right?
Optional.
Optional.
It's the debrief for.
Oh, okay. All right.
Is she here?
Yeah. She had a doctor's appointment from 1 to 2.